This video describes the Laura Roselli Cardiac Trainer, a dry lab cardiac simulator intended for consistent and deliberate practice of cardiac surgical techniques by residents and other practitioners of cardiovascular surgery. Cardiac surgery procedures in the current era demand an increasingly sophisticated level of technical skills. Training new practitioners in this era is challenging. The depth, constraints, and delicacy of tissue within the mediastinum demand a facility with longer working distances, needle angles, and needle handling that many residents have not experienced until they start their training. The Laura Roselli Cardiac Trainer was designed by surgeons from the Cleveland Clinic's Heart and Vascular Institute in conjunction with the Cleveland Clinic's Innovation Center. A variety of skill sets can be practiced, including, but not limited to, aortic valve procedures, coronary anastomosis, cannulation, aortic graft anastomosis, and mitral annuloplasty. The goal was to provide an inexpensive and readily accessible working box based on real-life measurements obtained from 3D reconstructions of a variety of chest CT scans. This enabled us to create a high-fidelity feel to the box while utilizing inexpensive and readily accessible substrates. The trainer is shaped in a hexagon configuration and has holes at the base that enable a variety of interchangeable stations devoted to distinct surgical techniques. The box is compact, portable, and fits on any desktop or other working station. The first station shown in this video is the cannulating station. In this exercise, the semicircular textured surface mimics the ascending aorta. It is anchored at the desired depth and angle within the box to mimic the exposure for cannulating the aorta. The material of the cannulating surface is made of headliner fabric, which is durable enough to last several exercises, but delicate enough to simulate the delicacy of technique required for the exercise. With this configuration, the resident can practice the needle depths, angles, and handling of the needle driver required for cannulating in the real setting. More importantly, the resident can practice this exercise numerous times in a short setting. By changing the angle of the device, one can simulate cannulating angles required for the atrium, femoral vessels, or other structures. To switch stations, one simply unscrews the insert and attaches the next station, which is in this case the coronary station. The material is similar to the cannulating station, except that 8mm holes are machine punched to simulate distal and proximal coronary targets. An additional arm insert can be used to simulate the assistant retracting the vein or arterial graft. We have manufactured tubes out of polyester fabric to allow an inexpensive and readily accessible conduit option for practice. The material is durable, but delicate enough to simulate the real setting. Other commercially available coronary conduits are expensive and difficult to obtain. By angling the surface in different locations within the box, one can mimic a variety of distal and proximal scenarios, including the PDA anastomosis, the circumflex, or the LAD. By performing this anastomosis with fine suture, Castroviejos, and vine pickups, the resident experiences the delicacy required to practice this anastomosis, the angles necessary to work within the box without backwalling the targets, the needle handling with the castros and forceps, and the spacing required for a proper anastomosis. This can be repeated multiple times simply by cutting the suture, pulling it out, and starting over again with a new one. The exercise enables the resident to identify his or her strengths with coronary work. Ideally, the needle should slide right through the tissue without torque or resistance. The tissue should be manipulated and retracted with care and precision. In the end, one should have a completed anastomosis with evenly spaced suture, no tears, no air knots, and no loose sutures. The next station is the aortic or graft-to-graft anastomosis. This station can be configured in multiple ways to simulate either a hemiarch, elephant trunk, ascending, or proximal aortic anastomosis. The material is similar to that used for the coronaries. The station has two arms that can be angled in multiple degrees of freedom. Once the back wall of the anastomosis is completed, the graft is slipped off the holder to bring them together and complete the front wall. Notice that the resident again can practice the delicacy required for working in this setting, the angles of the needles, the needle handling with long needle drivers or castros, the spacing, and the economy of organizing the sutures to prevent locking or tangling. At the conclusion of this exercise, there should again be evenly spaced sutures, no tears, no loose sutures, and no air knots. The aortic valve station uses yet another multifaceted arm with several degrees of freedom attached to a plastic cylinder which mimics the hemi-transected proximal aorta. Within the base of the cylinder lies the aortic annulus, made of cylindrical headliner material. A holder can be used to stabilize a ring of polyester material or any other material which is used to mimic the sewing ring of an aortic valve. The main focus of this exercise is to give the resident facility with suturing within the constraints of the box and the cylinder which houses the annulus, or the mediastinum and the aorta, respectively, as in the real setting. The resident works carefully around the ring, mimicking the needle angles required for standard aortic valve replacement. In this case, a continuous suture is being used to conserve suture, although interrupted sutures can be used, or the needle alone with a small tail can be used to simply simulate the needle angles, which is the main purpose of the exercise. The resident again practices spacing, needle handling, and delicacy of technique with this exercise, which can be repeated multiple times in a short setting. A separate insert was designed to simulate the mitral annulus within the left atrium, which is used in a similar manner to that described for the aortic valve. We hope that this cardiac trainer will provide residents and other practitioners of cardiovascular surgery with a useful tool. It is compact, affordable, and readily accessible for repetitive practice. We are currently solidifying relationships with industry to sponsor and distribute the trainer to residents in the United States and abroad. We are also working closely with the Thoracic Surgery Residents Association to help validate the use of the simulator and to improve the simulator for continued use by trainees. Thank you.